great pleasure to see you all, and it is even greater pleasure, or an equal pleasure, to introduce Elizabeth Root, Associate Professor of Geography and Public Health at Ohio State. Elizabeth works at the intersection of geography and health sciences and demography, thinking about topics including the effects of environment and climate on population health. She has that key attribute of every great social scientist, which is a broad and deep curiosity. We see this curiosity for a wide range of topics in her history. She lived in Zimbabwe as an undergraduate. She worked for RTI, Research Triangle Institute, on policy-relevant research. She studied anthropology and policy and geography and population studies. We also see this broad curiosity in her current research projects. She has fieldwork in Bangladesh, Honduras, and in the Philippines. Her survey instrument, I believe that she said that the current survey instrument is 9 hours of survey questions. And as you might imagine, for that length includes not only questions about income or sections on income and consumption and health, but also cognition and kinship and climate. Her wide range of scholarly interests is further reflected in the range of her grants and publications. Like many of our brown bag presenters, she has funding from NICHD and NIA, and she's published in PLOS and Social Science and Medicine and PNAS. But she also gets funding from NOAA and from the EPA. She also publishes in journals like Health and Place, the New England Journal of Medicine, and the Annals of the Association of American Geographers. Elizabeth earned her BA at Pomona College in 1999 and her PhD at UNC Chapel Hill with that well-known group related to geography and population in 2009. She began working as an assistant professor at UC Boulder, was there from 2009 through 2015, and then had a variety of offers but chose to go to Ohio State in a position with tenure in geography and public health. And interesting, as we're thinking about the changing nature of demography and data science on the Berkeley campus, her position at Ohio State was funded through a data science initiative. So it is my great pleasure to welcome Elizabeth.
What I'm going to talk about today is actually a very new project. We just finished field work at the end of the summer, this last summer. And I'm going to share with you why we did this project, because it's really unusual in a lot of aspects, but also the very first look at some of the data that's coming out of it. But just keep in mind, the data literally came in probably September of 2016. And we did all of our data collection using tablets and electronic for the first time in my career. Which was an adventure in and of itself. So we have this ability to more rapidly sort of look at a lot of the data that we got in through this. This project also may not seem like something that a population scientist might be interested in. It's really about this concept of decentralization in a global health perspective. Granted, those of us who do population science work all over in all sorts of different topics, right? But decentralization has really been the purview of economists and political scientists, I think, for most of the discussion about it in the literature. So you ask yourself, how in the world does a geographer get involved in this? And then the team actually that I work with is very broad, crisscrosses sociology, geography, demography, and poli-sci. So what did we all have to add to this question moving forward? And that's why I thought it might be particularly appropriate for this audience, since I know all of you are very broad in your interests. So, as we all know, there was a great success, theoretically, with the Millennium Development Goals. We saw many countries reach many of these goals from the time they were set until they were replaced, actually, in 2015 by the Sustainable Development Goals, which are now our new set of global health and development goals. Because I guess we did such a good job reaching the other ones, we needed to reframe it all and try to think more broadly, actually, about how we create healthy communities and how we create situations in which development is actually furthering poverty reduction strategies and things like that. So what's interesting, though, is across the world, you'll realize that there is a tremendous amount of heterogeneity and inequality in how these goals have been set and how these goals have been met, right? So some countries are doing a really good job in reducing infant mortality and maternal mortality and decreasing fertility and all these different goals, and some are barely making the most basic health indicators. So one of the things the WHO has in their reframing, early in 2000s, but then in their reframing, they really made this statement that the first challenge to meeting all of these goals, right, and making healthier communities is to strengthen health systems. And that in the absence of efficient and good health systems that really further all of these goals, we won't actually be able to make a lot more progress on many of the goals that we've set for ourselves as a global health community. And so really, they tasked scientists with trying to understand how we can strengthen health systems and how we can change the way we do public health in a lot of these settings to more efficiently provide for children and moms and communities across the globe. So the motivation for this project is really around that concept of how do we strengthen public health systems? How do we do this? The problem, of course, is that in many developing countries, I don't know how many of you have worked in less developed countries around the world. As you mentioned, I have worked in Honduras and Bangladesh and the Philippines and India and a variety of other settings. And really what I've noticed there, and what most research scientists would say, is that public services often don't work for the poor. They may still work for the wealthier set in a developing country or in a less developed country, but they really don't seem to be effectively reaching the poor, and they're particularly the bad in rural areas, right? So we're not doing a good job of providing care. So there's been now about 30 years or more, probably closer to 40 years, of different institutional reforms that have been enacted in different settings to try to improve local health governance, right, and the way health systems operate at a local level. And decentralization has been touted as the thing that's going to solve it all, right? So decentralization is a tricky term because what does it even really mean? Actually, the United States has an almost entirely decentralized health system. We don't think of it that way, but our system is run by not a central government like the British health system is. That is a truly centralized system. It's run not even a little bit by our government, really, right? It's run by a bunch of private entities that provide health insurance and run hospitals and hire doctors and whatnot. So we actually have a fully decentralized system. And what we can say about the American health system is that there's deep inequality, right? And that's one of the things that the WHO and decentralization was supposed to not do, right? It was supposed to lessen inequality in these areas. So somewhere between 70 and 80% of all countries around the world are experimenting with some form of decentralization. As I said, the British health system is one of the few truly fully centralized systems in the world that we have. And they are very proud of it, and it is a very effective system for improving health. But the issue is that there's very mixed theory, on what decentralization should do, and very little rigorous empirical evidence to show whether or not decentralization is effective, okay? So WHO and most of the major sort of political, economic players in the global health world are touting it as the way to go for less developed countries. And yet we have almost no empirical evidence to prove that decentralization does what the WHO said it's supposed to do.
And so they're decentralizing from a effective centralized system, or that the health system they're going to build is a decentralized one? In other words, if the UK decentralized, that would...
Right.
What's the change?
Well, so most less developed countries, and I'm generalizing here, right, because there's different, part of the issue, of course, is that there are many different types of models of health systems. But most of them, there is some sort of Ministry of Health that has central control over the health system, right? So payments and things like that flow through a Ministry of Health, which is that top level. And that would be considered a centralized system. So most of the lesser developed countries are starting there and going from there in some way, shape, or form. And what you'll see in Honduras, which is basically my case study, is that there's not one form for how that decentralization actually happens, right? It doesn't just devolve down to municipalities and suddenly, bam, the municipalities are running it. In Honduras, they actually did NGOs, something called mancomunidades, which are like local entities that are sort of underneath municipalities. So that's part of the trick, and then what I'll talk about more about. But most of them, think of it as starting with like a Ministry of Health that was doing everything, and then decentralizing from there in some way. So, what is decentralization? Okay, so basically at its core, the concept of decentralization means that you have fiscal, administrative, or some sort of political authority over health services and the health system is actually shifted to a lower level of the government, or some sort of a lower entity that isn't like a Ministry of Health, which is an umbrella, right? So there's 3 groups in the decentralization literature that sort of have a theory about why this is a good idea. There are the proponents, and there's a couple of major players in the proponent debate, and they basically say that there's going to be superior information and clear accountability at this local level, and so the local actors will be better at making decisions and about what the population in that local area needs, and so therefore you should have better health outcomes. So that's one of the ideas behind it. So it's all about accountability at a local level, and so therefore that accountability will translate into better services and better outcomes, okay? There are the opponents, or the skeptics, as we say, and they essentially say that devolving this authority down to some local level reinforces existing power inequalities that already exist. And so therefore, and especially economic inequalities that exist, and so therefore may not be effective, right? Because those inequalities are still there, and that would still translate into inequalities in health. And then there's the conditionalists, which I would say the co-PI on this is a conditionalist, Krister Anderson, who sort of say it's possible that under some structures, the way the local health system is set up, that this could be an effective method. But you have to make sure that sort of there's equality in the political and economic ties that create this local health system. I personally would say that I fall in the skeptic or opponent category, just to sort of lay it out there for y'all so you know where I'm at. But it's partially actually due to none of these arguments. It has to do with my childhood. My father ran hospitals. My father is he does health services research, and he ran hospitals. And I remember sitting around the dinner table one night, I swear to God, I was like 12 years old. And he said to me that he was talking about this grant that his department had got. And the grant was to bring in public health services type people from, I believe it was Kenya, but that little thing eludes me, Kenya, and they were going to train them for 6 weeks at the University of Washington in how to run local health systems. Because what he said was, they have no training in this at all. They have no idea how to run a local health system, right? And so to devolve power to a group of people in a local level who have no training or capacity to run a local health system seems to me to be setting people up for failure. So that is why I stand on the skeptic category. What's interesting about this grant is we are going to get at some of that because we're collecting information on players that are operating the public health system and what their skills and the way they view their role and the ties that they have to community organizations. So, the state of the knowledge. Why did we do this study? Well, so here are 3 major studies about decentralization that came out over the last 20 years or so. And essentially, there's a paradox in here. Some people, their results from studies that they have done, one can prove or disprove almost any proposition about decentralization by throwing together some set of cases or data. So a lot of decentralization studies are done by doing small case studies and comparing different countries to one another. One country that had a majorly decentralized system and one that didn't. The contexts are totally different. Those countries are totally different. The political economy is totally different. So how can you compare those in a rigorous way, is what basically this is saying. There's another one that says decentralization sometimes improved and other times worsened service delivery, corruption, macroeconomic stability, and growth. So here's a mixed outcome within the study itself. And then this is one of my favorites. To date, there are almost no solidly established general empirical findings about the consequences of decentralization. So basically, we can't say anything. Yeah?
Sorry, is this limited to decentralization like within a government system, so centralized government to decentralized government, or are you considering studies that involve like a private service provider?
Well, so a private service provider would be a decentralization model.
Okay.
because it's still not government controlled. Every time you hand something over to a private organization, you've handed over government control and essentially decentralized the program. And I don't know of any models where the entire health system of the whole country was handed over to a private entity. It's usually some small area or a region or one piece, like vaccines, that gets handed over. So the more you partition it up, the more decentralized it becomes. But the question you ask actually gets to the heart of the debate in the literature, is how do you even define what decentralization means, right? And there's so many different models and ways of doing it that it's hard to compare results, it's hard to have case studies, it's hard to compare one country to another, because they're just so dramatically different from one another. So I think that's one of the reasons this debate exists in the literature. So basically, after about 50 years of experimenting with all kinds of decentralization models across the globe, we don't really know, is the answer. We don't know if it's effective, we don't know how it's effective, if it seems to have been effective. And so there's a lot more research that actually needs to be done to figure out what the effective models are to improve health in these countries. So I think there's 3 or 4 reasons why we don't know more that we should. There's conceptual confusion, which is kind of what I've been trying to get at is, what is decentralization? Where has it been implemented, right? Like, what does this even mean? Do we not need to think of it as decentralization, but do we need to dig deeper into it and decide, this is one type of decentralization, this is one model of decentralization. Let's look at these different ways of doing it and compare. There's been a lot of non-rigorous empirical research that has been done. A lot of it has, the quantitative studies typically are cross-country studies. They'll take something like, the WHO's data set on infant mortality and, all the different indicators from the WHO observatory that you can pull off from their website. Or some of them, I think there's one that actually used DHS data from 90 different countries or something like that. And sort of made a case that this country decentralized and this country didn't, and this is the resulting difference we see over time in different health outcomes, right? But these cross-country studies are really hard because you're comparing sometimes apples to oranges. And there's a lot of qualitative studies that have been done, but they of course have a very small n and a large x in that there's a lot of variation and things that we need to consider when looking at it. Country-level analyses, sort of these top-down country-level analyses, cross-sectional things, they actually ignore within-country variation. And this is where the geographer came into play. Because what happens in one side of the country is not what happens. Look at California versus, say, where I live in Ohio, right? What's happening in these 2 states right now is really, really different, right? So to think that any country is different than that, I find challenging as a geographer. There's so much within-country variation. So what we think is happening from some work that we've done previously in Honduras is that some local systems seem to actually be very effective and they seem to work really well. And some local systems don't. And the question is, why, right? What's driving that difference, right, within the country? So, we don't know more because we're asking the wrong question, in my opinion. We're asking, is decentralization good or bad? Or does it work or does it not work? When really we ought to be asking a question, why do some of these decentralized local health systems seem to work while others don't, right? This is a fundamental reframing of the question that's being asked in the decentralization literature, which I think is a really important way to go. So that brings us to Ensago, which we sat over dinner in Honduras trying to figure out what to call our survey, because you have to have a snappy name when you do a survey, right? And we came up with Ensago, which means Encuestas de Salud and Gobernanza, because it asks about health, right? We're looking at health and demographics, but there's also a huge component of the survey that's looking at how the health system is basically run, right? Governed in these particular areas. So we called it Ensago. It is examining how the local context of decentralization affects variation in health system performance and then in health outcomes across Honduras, across the whole of Honduras. It's very interdisciplinary. As I said, there's a political scientist, there's sociologists, there's geography, that's me. Because it was funded by something called the NSF, Interdisciplinary Behavioral and Social Science Mechanism. Did anybody hear about this? Came out like 3 years ago now, probably will never be done again. But you could not apply for the funding if you didn't have 3 different PIs from 3 different social or behavioral science disciplines. So that's how political science, sociology, and geography got thrown together. But it's a very interesting mechanism because you had to show that the work was truly coming at a question from multiple disciplinary ideals, right? And so when Krista Anderson and Jane Mencken and I sat down, Jane was like, well, I wonder how this is working. I mean, she's very interested in fertility, so we had a long discussion about contraception and how that was provided and whatnot. Krista is almost entirely interested in the actual governance structure, right? So how different entities within that local governance structure interact with one another, right? And talk to one another and share resources and how that relates to health systems. And I looked at it and I said, yeah, but you talking about the Mosquito Coast, which is like drug cartels and, I mean, it's a really, we couldn't even actually go there because our survey firm would not go there. And we're talking about the capital of Tegucigalpa, right? These are really contextually different places, and the governance structures are different in these areas. So it came together, right? And we felt we had a really innovative idea, which was to highlight how decentralization reforms are kind of filtered and mitigated by all of these local level institutional arrangements and local contextual whatever to produce health systems and health outcomes in specific areas. And NSF bought it, and we got the money. So, so the study goals were kind of threefold. You have to have 3 study goals when you put in that proposal. The first, which is the one that was most near and dear to my heart, was that we needed to examine the effects of decentralization on health system performance and community health outcomes. Right? That's the basics. We gotta look at this and even see if health outcomes are changing over time as decentralization rolls out in this country. Understand organizational characteristics that condition the effectiveness of decentralization. This is getting at that how the local governance structure works. This is more of Krister's area. And then explore the structure of relationships within health systems and ties between actors. And there's actually a social network component to this, right? We can build community social networks to look at how all of these community organizations are linked and are sharing information and resources, and understand how that affects the effectiveness of the health system. So it's really an interesting and very broad study. So, how many people know anything about Honduras, other than there's lots of drug cartels down there? Oh good, I actually have some Hondurans. Okay, Honduran people, you know about Honduras, not Honduras. So Honduras, of course, is right here in Central America, next to Nicaragua, El Salvador, and Guatemala. It has a very long history of conflict, border disputes, international, mostly US, intervention, agricultural monopolies, drug trafficking, natural disasters. There's a Hurricane Mitch that hit and just demolished part of the coastline of Honduras. So it has a very tumultuous past. Most recently, there was a military coup in about 2009. This is me way oversimplifying the political condition of Honduras. It was a fairly widely condemned political coup across the world. And it was related to a little bit to the fact that Zelaya, who was in power prior to that, he really had a bit of a socialist leftist bent. And Honduras has been dominated by the banana world, right? All the large agricultural, globalized agriculture related a lot to bananas and coffee. And so there's a very large, not so socialist bent, strong political sort of lobby going on in Honduras. And Zelaya was elected, and he began this process of decentralization during his administration. And there were a lot of things that he did that did not sit well with what was going on with a lot of the big players in Honduras. And so this military coup occurred, and then Lobo was elected in 2010. And that's kind of where we are now. You have to be careful when you go to Honduras, is all I have to say about that. Honduras is very poor, for lack of a better term, and they have a lot of challenges that face them. This is just population below $1.25 a day. Everybody knows these graphs, and you can see that Honduras leads the pack up here as this dotted line on the top. It often gets compared most to Guatemala. There's some very strong similarities between sort of the economic and social situation in Guatemala and Honduras. And indeed, children under 5 underweight, one of our hallmarks for how well we're doing with the kids. Honduras, again, is this dotted line. It's not quite as bad as Guatemala, apparently, but it's definitely above all of the other countries that are in Central America, right? So there's some serious poverty, structural problems in Honduras that have led to poorer health outcomes in this area. You can also, of course, look at like something like the HDI, the Human Development Index. Darker colors mean a lower Human Development Index. So over here, poorer populations. This is the Mosquito Coast that I was talking about, which is largely indigenous. Large indigenous population lives in that area. And then this is sort of some of the, up there, if you ever went on a vacation to Honduras, you would be on one of those islands or along this coast. That's where the majority of the tourist industry resides, if you could actually ever go to Honduras. And here's an interesting prenatal health services. Again, darker means fewer prenatal health services. So there's issues along the coast up here, Mosquito Coast over there, and some of these highland areas which are quite remote in access to prenatal care services. So Honduran health sector reform. What happened in 2005 when there was this decision to decentralize the health system? So this is the way it used to look. So here's the model we started with in this particular context. There was a national Ministry of Health. There was something called regional health authorities, which were collections of municipalities. By the way, these are the municipalities, or actually those are districts. So the regional health authorities sort of had administrative control over what was going on in the local health centers. But there's really nothing in between here, right? There's nothing that's sort of barring the way between these regional health authorities saying, okay, local health center, you need vaccines, we'll get you vaccines, right? That's the way it flowed. And the money flows this way too. So the money flowed from the National Ministry of Health through these regional health authorities down to the local health centers, which is important, right? What happened with under decentralization is you have the National Ministry of Health, there's still these regional health authorities, although their authority has been greatly reduced, right? They're sort of now overseeing all of these other organizations that have popped up in between, right here. And it's a very mixed bag in Honduras. There are NGOs that are responsible for providing care at these local health centers. There's municipalities that have decided that they will take over the job of administering the local health centers, like an entire municipality. And then there's local organizations, as I said, called mancomunidades, which are not municipality level, they're kind of under municipality level, and they're just groups of local organizations that have decided to get together and run their local health center. So there's actually 3 models simultaneously being implemented in Honduras at the same time. This is called devolution in the decentralization speak, when you have something like a national Ministry of Health or a regional health authority that devolves control down to a local level.
Is there some sort of competitive mechanism
for how these organizations were chosen?
Or does the regional help us?
I would say the intent was that there was a competitive mechanism, but in reality, the government of Honduras is so corrupt that it was sort of like whoever got in there at the right time and, you know, passed a buck. I mean, honestly, probably did the handshake the right way, was given authority over some of these local health systems. And that's another problem, right, is that many countries experience this sort of chaos at the point of decentralization.
Was there a reason why these 3 models were chosen? That's kind of how it went.
That's just kind of how it went. There was no intent at the outset that was going to happen when they decentralized. But essentially the Ministry of Health said, we're going to decentralize. Give us your municipalities or local or regional health authorities, give us your best on how we can do this. Like, who's going to run these things now? And all sorts of different things popped up. The fact that an NGO that may not even be a Honduran-based NGO is running some of these local health systems is a little mind-boggling, right? And I mean, it's just very interesting, right, to see all this happen. Did you have another question?
Yeah, was there any motivation from other countries' experience in Central America doing this?
Ostensibly, yes. But when you actually look at the way that it was carried out, it doesn't really look like it. It wasn't like, oh, it happened really well in Costa Rica. Let's take Costa Rica's model and apply it here. It was not that organized or well thought out. So it sounds very chaotic, doesn't it? It's kind of my experience of it too. So here's what's very interesting about what Honduras did, is they decided to roll out decentralization. They didn't just take the whole country and say, everybody's decentralized now. They decided they were going to roll this out over a period of time. And actually, they rolled it out in about half the country and stopped and haven't proceeded, probably because of the turnover in the administration, right, and who was controlling the country. But what it did was it set up a quasi-experimental study design, right? It set up a natural experiment for us, where we have portions of the country that were decentralized and areas that are still under Ministry of Health control. This actually shows you sort of how it's these municipalities, so this is now a map of the municipalities, how what the governance style is in each of these. So the purple are still centralized, and then there were kind of two waves of decentralization. There was what we call the pre-2009, these were the tester sites. These were sites that they were tested things on to see how it would work. They're mostly located over near the capital. Just I think that was literally a geographic decision. They were close, they were easy to observe what was going on. And then we have this set between 2009 and 2011 that were decentralized. That's the darker color. And then there's some that were partially decentralized. So only parts of the municipality have local governance structure. The other part is still administered by the Ministry of Health. And those also were political decisions, right? So that was all politics too. Yeah.
What's this, I mean, what's the scale, what's the travel scale here? I know the mosquito coast is very hard to access.
Yeah.
That's far away. Among the, like here in the whatever the western
yeah.
northern part.
Well, everything's kind of hard to get to. I mean, right? So this is the capital region down here. It would take, it would take probably a day and a half to get to the sites that were up here that we sampled. And then moving around them takes a little while too. So, and it's mostly done by like motorbikes. There are not a lot of paved roads, it's mostly dirt roads. Yeah, so it's not that big of a country, but it's one of those countries where travel is still really difficult within the country. And there's really like there's one airport up here and then there's one in the capital, and that's kind of it. So air travel is pretty limited too. So, study design. We have this quasi-experimental design that's due out to do this rollout, and we're going to harness this, right? We're going to try to use this so that we can do a within-country comparison and not have to worry about the fact that Honduras and Nicaragua are very different countries with very different contexts. We selected a subset of municipalities, and we did use propensity score matching because we have a lot of options here in the purple, and we're certainly not going to all of them. So we had to choose some of these selectively somehow to compare to the municipalities that we chose that were decentralized. So we basically took all of the decentralized ones that were post-2009, partially because these were sort of done weirdly, and these were done in sort of like, boom, you're decentralized. The other ones were a little more touchy-feely, shall we say, the government. And then we used propensity score matching on a whole host of demographic and health services and governance style data that we garnered from the government to match these decentralized to one or probably two, really, one centralized area. Yeah.
In terms of the three different models of decentralization,
Yes.
is that spread
Yes.
evenly across?
So we did think about that. You notice we have 42 decentralized and 23 centralized, and the 42 decentralized break up fairly evenly into these three different governance styles. And then we have fewer decentralized because we're comparing 3 in here to 1 over here, right?
Were earlier municipalities that were decentralized more likely to use one model versus the other?
No, there doesn't seem to be any rhyme or reason to that.
Let's try to hold questions a little bit so she can get through.
She's worried that I'm not going to get through on time. So we have 5 data collection strategies, actually, as part of our survey. We compiled data on health services and socioeconomic attributes. We got this from the census in Honduras and the Ministry of Health in Honduras. They actually shared data with us. Wow. We had a health personnel survey. We went to all of these health centers in the select municipalities that we had, and then we interviewed health personnel in the different health centers. We did a community survey where we went into the community and we actually asked about organizations and whatnot that were in that community. We did the household survey, which is what I'm going to talk about, and what I did as part, this is me, and actually I did some of this too. And then there was actually qualitative semi-structured interviews before all of this to help us craft the surveys that we did do in the end. So it's a very multifaceted study design. So we selected all municipalities with at least 4 years under decentralization by 2016, which is when we started the survey. The control municipalities were matched, as I said. And actually, I'll have you know the post-matching was quite reasonably balanced. If you know anything about propensity scores, the treated group distance was about 6.2, and it was control group was 5.59, so not too shabby. We're doing robustness checks where we're taking a section of the treated group and sections of the control group and comparing to see if our results hold as we do this, just to make sure our propensity score matching doesn't somehow mess it up. And this is what we ended up with. We have control here. These are our blue control states. We have treated in the green, right? So you can see sort of the geographic distribution of, and these little dot things are here, the propensity scores, but I told my grad student to take that out, but he really liked it, so we kept it in. So you can sort of see. We did exclude a few because they just, either people didn't want to go there, the survey firm were not comfortable going to these places, or they just weren't quite as good a match, so we excluded them from the outset. There's a couple different reasons which I could talk more about, but. So what I'm going to do now is I'm going to show you some very initial results. I'm going to examine the effect of decentralization on mostly community health outcomes. I'm going to focus on child health and health services because you could look at lots of different health outcomes in this, but I want to look at children's health partially because that was one of the focuses of the decentralization process in Honduras, was improving child health. And so we can start to look at how this plays out in these different areas. So what I used was, we actually used a combination of our Ensago survey and the DHS. We were really fortunate. The 2005-2006 Demographic Health Survey was done in Honduras before decentralization occurred, like literally the year before the decentralization process started. So we lucked out at the timing of this. And it's not one of the little DHSs, it was a big DHS. It had a massive sample size to create municipality level estimates. So we were fortunate and we basically piggybacked on the DHS. And in fact, our survey, our household survey, has many of the same questions so that we could look at a pre-post study design piggybacking on the DHS. And we actually used the same sampling strategy and all of that for our survey so it would match up. We ended up with about actually 10,000 households in the end, closer to 150 per municipality, which was similar to the DHS. And of course, we have a ton of health outcome indicators we can look at. I'm going to show you a subset because the DHS has more data than anybody knows what to do with, if you've ever used it. So what I'll do now is examine some simple trends for these municipalities that we looked at. Using the 2005-2006, there's actually 2011-12 DHS that was done too, so we have an intermediate time period. I can't use that in the models because it's messy, it gets messy in what was happening. And then our survey in 2016. And I did some difference in difference models to start exploring the effect of decentralization. I don't know how many people have ever looked at a difference in difference model. They're pretty simple in some respects. They're kind of elegant, and they're very, you have to have a good study design for them to work in all of their elegance, of course, and we felt like we did a pretty darn good job of our study design. But essentially what's really important is their regression equations, and what's really important is this beta right here, this beta coefficient. And what it's telling you is the treatment effect, right? It's saying, if you look at the treatment over time, did the treatment group have a different outcome than the control group, right? So did our decentralization group have a different outcome or a different slope for that particular outcome over time than our control group, our centralized groups? And I actually like this visualization of it, right? So this is our control group, this is our treated group up here. You have a pre-post setup, right? You have data at 2 different points in time. Sometime between those 2 periods, the intervention happened, or whatever happened, right? And what you expect is if the treated actually had some effect from this, from the decentralization, we should see a differential slope, right? The only issue about these models is that this doesn't have to be the same, right? Baseline can be different between the treated and the control groups, which is good because they are a little bit. I'll show you that. But the slope before over here has to be the same. So if you were to look from like here to here, the slope should be the same in this group and in this group. Because only then can you make the assumption that the treatment actually changed the slope in some way. Fortunately, because of that 2010-2011 DHS, we can look at that with these data, which is very interesting. So I don't know, it's like a perfect storm of data. It's very exciting for me as a data scientist. So what do we see? health has improved in Honduras over time. You could actually go to the DHS and you could see that, right? This is really simply looking at some of the major outcome variables, weight for age and height for age, Z-scores, all of the vaccination, right, indicators. And then these ones are more related to health services, antenatal visits, prenatal visits, and then where people delivered, because that was a big issue. There was a lot of home delivery in Honduras still, as far back as 2005. So here's sort of the here's the post. These are only our municipalities in our sample. This is not all of Honduras. I'm narrowing this down to the Sagos sample, both pre and post. And you can see that over time, Z-scores have gotten better, right? So kids are taller and way more. We have higher vaccination rates, although this is, they were already pretty high for DPT and for BCG, so there wasn't much movement there. And that women are increasingly getting in for prenatal visits, and that home deliveries are going down. Why these are called MCH, they have these specialized birthing centers now, have gone up. So, you know, basically things are going pretty well in this country if you want to look at it purely by the numbers. And this is what you get out of the DHS report. Now what we can look for here is sort of, these are the 3 different points in time now. These are the 3 different surveys. And this is at the point at which a lot of decentralization occurred. So you can sort of look at the beginning and the end of these 2 slopes and see that the slopes are, you know, they're sort of, there seems to be for many of these things a steeper slope going after 2010. But this is just really to visualize what this horribly ugly table looks at, right? So this is what we're seeing over time. You see length for age and weight for age, we're seeing gains here, right? You don't want a negative Z-score, that's bad, you want a positive Z-score. Weight for length actually changes, and this is partially related to changes in BMI. Children are getting fatter, so that's not necessarily good, but they are getting fatter, as we see in most developing countries as they develop. Immunizations, there were major gains made in measles immunization over time. All the other ones had fairly high and have sustained fairly high vaccination levels. That's good, right? We want to see that. Prenatal care, here's the MCH deliveries are going up. That's good. That's a skilled birthing center. We see home deliveries take a nosedive over time. And we see antenatal care visits increase, which is good, although it's pretty high to begin with. This is the other one that I think is interesting. One of the major pushes of decentralization was a growth monitoring program, where you would go and the kid would get seen for 3 months and then every year until they're 5 years old. And there was definitely a fairly dramatic increase in growth monitoring across the board, and pretty much across the entire country. So that was a major push by the central government actually as well. So this is looking at baseline. One of the things you have to be careful of is sort of understanding what the differences are between the treatment and the control group, our centralized and decentralized groups, pre and post, at baseline, right, in 2005. And actually what you basically see is that there's not a heck of a lot of difference between the decentralized and the centralized areas, which you shouldn't see because they were all centralized at that point, right? They were not theoretically any different at the time. So there were some slight differences in height for age and weight for age in the Z-scores, and then down here in growth monitoring, actually. The control groups, the control group actually had much worse growth monitoring programs than what eventually ended up being the decentralized programs. So I'm not really, I think it was partially because it was targeted at really poor rural areas, but we're digging into that one a little bit more. So this is where we can see if the difference in difference models will work, right? What we need to look for is between here and here, we need to see a similarity of slope, right? Because this is when, right about here is when the decentralized program was rolled in, late 2009. And the DHS was done in 2010, actually 2009, 2010. 2010, it was basically all in 2010, according to the Ministry of Health. And what we see actually is pretty good, right? Length for age, these mirror each other. And then there are some differences between the treatment and the control. This pretty much mirrors, and then there's differences again. And similar for that. So in terms of our child health outcomes, sort of the nutritional outcomes, difference in difference models probably will effectively measure a treatment effect because the pre-period they have similar slopes. So that's kind of what we're looking at here. This is immunization. What I have been told after subsequently looking at immunization and actually in talking with the Ministry of Health is that this is one of the few programs in Honduras that was not decentralized. So pretty much we have a vertical program in Honduras that's still targeting children for vaccination. So this is one of the things where I would actually expect to see no treatment effect because there's a difference in the way services are being delivered for vaccination. It actually serves as a really interesting control for us because this is a set of services that hasn't been decentralized, actually. Isn't that interesting? That there's like one program that they decided the Ministry of Health was still going to administer across the entire country. Immunization is it. So you really don't see a difference between treatment and control because it's all being done by the same people. We'd kind of expect that. Prenatal care and delivery, again here with antenatal care visits, you see a similar slope and then a really big difference actually. One becomes negative, one becomes positive, that's interesting. Here we have home deliveries, basically the same slope and then they diverge. And then this one actually could be problematic, looking at MCH delivery, right? These slopes don't seem to match up very well. So this may be one where the difference in difference model shouldn't be used. And here's growth monitoring. This is kind of a bummer for me because there's obviously some really big differences, but this is growth monitoring in the centralized areas. It was a flat line between 2005 and 2010. And for some reason in the decentralized areas, they had already started making gains between 2005 and 2010, which then accelerated, and this one goes way up and catches up. So we need to do a little more sleuthing into what local level contextual issues were making this happen. So here's the preliminary difference in difference models. Again, a really big ugly table. Couldn't figure out a better way of doing it yet. Trying to think about better visualization of these data. But what we see is that there's not really a treatment effect, except in a couple of circumstances. The height for age z-score, we see a treatment effect here. A positive beta shows a positive treatment effect. So if this number right here is positive, it means that the decentralized areas are making better gains in that particular health outcome than the centralized areas. So it shows us that height for age z-score, children in those areas are making better gains in the decentralized areas. Antenatal visits, again, a positive treatment effect, so more antenatal visits. MCH delivery is a positive effect too, so more women are giving birth in MCH centers. And home delivery is negative, which is good, right? That one we actually want to see a flip sign, because you don't want women doing home deliveries without a skilled birth attendant. So that's what's going on here. So to me, these ones I could have taken out entirely because I shouldn't expect to see a treatment effect here, and indeed I don't, which I guess is good, right? You want to see that in our models. But what this implies to me is that something's going on, but we don't really know what it is yet, right? There's some gains being made in these decentralized areas. I did one other additional thing, because remember I've had the data for maybe 6 months. I actually broke it out by the different governance models. So these are the 3 different governance models we have: municipio, NGO, and mancomunidad. This is the municipality. And what you see is that some of these changes or some of these treatment effects are being driven by specific governance models. So the municipality level, right, which is, in my opinion, sort of like one step below the Ministry of Health, and it's not really that far removed. There's essentially no treatment effect in the municipality, ones that are being run by the municipal government. Where you see the treatment effect is in decentralized systems that are being run by NGOs and by these mancomunidades, right? And actually the child growth monitoring, there's, right here, right, this one, you see no effect here, but what it is that the effect is all with the centralized groups, right? They're making huge gains in the centralized communities, but not necessarily in these decentralized areas. So what this implies to me is that there are local governance structural issues that are leading to gains in some of these outcomes. And when we dig deeper in and look at all of these different outcomes and more, because we have lots more, because we have a big survey, we actually need to be doing it not just in this way, but we need to dig deeper and start looking at these contextual differences between the different areas. Because there's obviously much more nuanced effect going on here that most studies would miss because they don't have this kind of information. So next steps, my very preliminary conclusion is that child health and health services improved over the decades that we've been looking at. That's clear. Honduras has made some really great gains in providing for the population. This trend is actually apparent in the full DHS data sets too, so if you look at everything across the whole country, urban, rural, all of it, you see these trends. So it's not just in our data set, it's the whole of Honduras. Decentralization, I would say, per se, does not appear to have an effect on most of the health outcomes, except for maybe weight for age. Decentralization might have an effect on provision of services, which actually was one of the goals of decentralization, is to provide health services in a different way. The health outcomes are sort of the natural extension of that, right? And it seems like some organizational structures in these local contexts may be more effective at implementing and running the health system than others. And this, I think, is where the really interesting stuff lies, right? So what are we going to do? We have more data cleaning to do. Does data cleaning ever end? Actually, that's what I've come to know as survey researchers. Data cleaning never ends. We have a lot of additional outcomes. We actually did what's called a health roster for the entire household. So we actually have a lot of information on chronic diseases too, not just child health outcomes that I really want to dig into. I want to add in some additional controls that capture household context, in particular socioeconomic status and household structure. I have to be careful though, because a lot of that information went into the propensity score matching. And so I don't want to unbalance my sample by adding in too much information. So we have to be really, really selective about this. And then this is the piece that I think is going to be fascinating, including variables that describe the difference between these different governance styles at this local context, rather than just sticking in a variable saying, oh, an NGO is running it, right? What is it about that NGO? Can we capture that? And we did, through these community surveys and the personnel surveys, we have that information. Again, we have to be very careful about unbalancing our propensity score match, because some of that information fed into the actual sample selection to begin with. So this is going to be a sort of a laborious process, I think. And the last one is to incorporate a social network analysis. We are very interested in how all of these local connections may perform better in the end, right? In particular, I want to see money. I want to see how money flows. And I want to see how, what institutional ties there are between major actors. So I work with so-and-so because I know them really well, because we know there's a lot of that goes on in the Honduran government, right? So I want to add this in as well. And that, I believe, is that. Thank you.
Okay, we've got about 10 minutes for questions.
Yeah. Oh, yes.
So I'm interested in the weight for age and
Yeah.
height by age and weight by height.
Right.
And I had the impression, well, partly from this, but more from earlier graphs and so on,
Yeah.
that there might be a positive effect of decentralization on weight, but it was a lot smaller than the really quite large effect on length or height.
Right.
And then, well, I guess the weight by height has height in the denominator in some sense.
Yeah.
And so that one either doesn't move or sometimes it goes down. And
Yeah.
but you said something about rising obesity of kids that I didn't understand. And what I'm wondering is whether, okay, these are health interventions and not direct economic interventions.
Right.
I'm wondering whether less diarrhea in childhood and so on has a bigger effect on height than on weight, or vice versa, or whether there's anything known about these kinds of issues.
So height takes longer to see an effect, because height is, sometimes people consider height a generational thing. And in fact, my study in Bangladesh, we're seeing generational differences in height, but we don't necessarily see like individual year differences in height. And it just takes a little bit, a while, I think, for height to catch back up. Weight, because of the interventions that are done with children, in particular growth monitoring programs, nutrition programs, they test for anemia now, they do all this, they sort of do a battery that's trying to make sure children are well nourished, and weight responds faster to that than height does. Height just takes a little longer to catch up in the big scheme of things. So it doesn't surprise me, right, that you might see some gains some places and not in others. The one that's kind of confusing is this weight for height. right? We do BMI by taking your height and taking your weight and applying a little equation to it, right? So this is essentially a BMI indicator. It's not quite, and remember these are Z-scores, right? So they're not actual ratios, we applied the WHO standards and created Z-scores. And actually what you see is that compared to the rest of the world, I guess you could say, Honduran children are underweight and stunted a bit because they have negative Z-scores right on that side. So I'm always a little suspect of this because I actually think BMI is a really horrible biometric measure, personally, because everybody's different. I mean, you have much smaller bones than I do, right? So therefore, your BMI should be different than me, even if we were the same height, right? So I actually don't like this, but it is one of those WHO standard metrics that's used. I'll probably take it out of my final analysis in the end because I just don't believe in it as a health researcher. We all have our opinions about BMI. That's my opinion about BMI. I have big bones now. Yeah, sorry.
It seems like your survey was conducted at a time that might be really nice to tie in Zika. And I was wondering if that was like one of the things that you guys were planning.
I actually added about 5 questions specifically on Zika because yes, Zika hit at the exact moment that we were going to the field. And so I asked a battery of questions. I asked about whether somebody had been diagnosed or if they knew somebody who'd been diagnosed. But I also asked knowledge questions.
Yeah.
I said, have you heard about, what do you know about Zika? What campaigns have you heard about? So yes, actually, we are ideally situated to have a very small research paper that says this is what Zika, this is what the population knew about Zika at the inception of this pretty much major health crisis in the area.
And possibly some minor effects.
Yeah.
Suggestive effects.
Yeah, absolutely. I mean, we should be able to even look at it by socioeconomic status and education level of the household and all sorts of stuff. If you have a student who's interested in that, let me know. It's like, I don't have a student who's interested in it yet. Yeah.
I was curious if you may have talked about this at the beginning a little bit, but could you give us a sense of just politically how it was decided which of these districts got decentralized and which didn't?
That's a really good question. Yes. So it was a deeply political decision. There were some municipalities that were actively, like municipal governments, that were actively lobbying to be decentralized. And many of them were sort of poorer rural districts because the promise of decentralization is that they would have control over their finances. Now, my question always is, did they think they were going to be able to put that money towards health services, or that they were going to get money and they could then choose to do what they wanted with it, which I think the latter is probably more likely in Honduras. But there was this promise of money flow that going to the municipalities, and so there was a good section of them that actively lobbied for it. In my understanding, there wasn't a municipality that was totally opposed to it that was forced to decentralize, which is good because you would think they'd probably not perform as effectively if they really didn't want to take on that role, but you never know, right? So for the most part, the ones that we decentralized wanted to be decentralized, which again may actually mess up analysis or may add another nuance to analysis. There's something about those municipalities because they were active to begin with that makes them unique, right? Which is again why we did all the other types of surveys rather than just a password survey. Let's try to get at some of that.
Just a quick,
Yeah.
It seems like if you could interview policymakers, you could like take pairs of municipalities that had the same propensity score and not tell them anything, say like, why do you think one of these got the treatment, one didn't, or something? And
I can't remember if Krister asked questions like that. I mean, we did things like that. Like we did go to all the major players and stakeholders that are running the system in each municipality or mancomunidad or local NGO, and we asked questions like, what was your decision about this? What were some of the thoughts that you had when you were doing this, or what were your options? So that was actually part of what I'm calling the community survey, which again, not to step on my PI's toes, right? That will probably be their paper when they write that one. But yeah, you're right. It is an interesting question.
I'm wondering for your inequality analyses, even though so many Hondurans are poor, are you planning to look at like just the poorest people in the municipalities and see who's receiving?
Yeah, who feels like they've got better services? Absolutely. I mean, there's so much possibility, I think, with this data. And these data, just so everybody in the room knows, will be public in like 2 years, right? So there's lots of options for things that can be done with them. But yes, I mean, I would like to look at it by, there's actually some really interesting ethnic things going on in Honduras. There's interesting socioeconomic issues. There's lots of ways of cutting this information. I did have a student who in Dubuca right here, she did more, I would say, qualitative interviewing on the ground one summer where she was going to women and asking them what their experiences were. And she did look at a wide range of people in different socioeconomic groups. And actually the poorest groups that she interviewed felt like there was better access to services. Like they weren't discriminated against quite as much when they came into the health center because it was their local health center. Which is interesting. But again, that's very small sample qualitative analysis, but it was really interesting to hear this when she did it. That's her master's degree.
I have some questions about the staff that might be employed in like NGOs.
Yeah.
Other type, like would NGOs be more likely to use a doctor, and was the payment different for doctors versus those employed under the centralized
Right.
system? Like are they salary versus fee for service or something like that? That changed with the implementation of decentralization.
Yeah, so health personnel differences. We actually collected all of that data. That's one of the things that I think will be responsive to these local contextual differences. By and large, there's not massive differences. There really aren't a lot of doctors anywhere in rural Honduras. It's almost all like nurse practitioner type folks that are taking the role in primary care. There might be, in the NGO ones, I would say there may be one more doctor that circulates around to all the different health centers. But again, there's not one at every health center, but somebody's circulating around. So and they are all on the same health, they're all paid the same way because they're technically government workers, even though they're not working, right? They're technically government workers, so they're all under the same structure, which means that they all have private practices on the side, which is kind of interesting. They're actually pulling in money from the community in a different way. That's a whole nother story. Something I learned about when I was in the field last summer.
Got time for one more? Even better.
Thank